Bismillahirrahmanirrahim. This video is about lung tumors, and for convenience the lung tumor section has been divided into two, lung tumor 1 and 2. This lung tumor 1 covers the etiopathogenesis and the morphology of most of the conventional type of the lung tumors, while in the lecture 2 of or section 2 of the lung tumors we are going to see the neuroendocrine tumors and some uncommon tumor of the lung as well as the metastatic tumor of the lung. So the learning objective for this lecture are, at the end of this lecture, the third year MBBS students should be able to describe the epidemiology of lung cancer, state its risk factors, classify different form of lung cancers, and explain its pathogenesis, define and illustrate with examples the paraneoplastic syndromes, and describe the staging system for lung cancer. So in the next hour, we'll be looking for the answer to some clinical problems. One is that a 63-year-old man present to your office after noticing that his left eye is droopy. In past history, there is some shortness of breath over the past 2 months, but he attributes that to his 40 years old heavy smoking habits. On physical examination, there is ptosis, meiosis of the left eye, and extremely dry skin of the left face. And chest X-ray revealed irregular mass in the apex of his left lung. Then there is another scenario in which a 71-year-old man present to your office because of water retention. He states that he keeps himself well hydrated, but he does not feel that his intake matches his output. There is shortness of breath and weight loss of about 15 pounds over past 3 months. He has smoked 2.5 pack of this cigarette per day for 50 years, and chest X-ray revealed a central quine lesions. A malignant tumor of epithelial origin is termed as carcinoma, and about 90 to 95% of the tumor that arise in this area are carcinoma, while about 5% of the tumors are carcinoid, and mesenchymal and other tumor comprise about 2 to 5% of the tumor that are present in this area. The lung cancer is the most frequently diagnosed major cancer. Globally, about 2.1 million new cases were diagnosed in 2018, while this lung cancer is also the most common cause of cancer mortality globally, and about 1.8 million deaths were due to this cancer globally. In United States, in 2018, about 230,000 new cases were diagnosed of this lung cancer that comprised about 14% of all the cancers. This number is significantly higher that was seen in 1950. In 1950, there were only 18,000 cases. That increased to 230,000 cases in 2018. That is significantly increased over the century. And this number in 2018, this accounted for about 150,000 deaths, and these deaths were 28% of all cancer deaths. According to International Agency for Cancer Research, that is located in France, the link for that is given here. In Pakistan, the 10,538 new cases of lung cancer were diagnosed in 2020, and these were about the total number of the cancer cases were 178,388, and this was about 5.9% of all the reported malignant cases, all the reported cancer cases from the Pakistan. When isolated for male or men, they were comprised about 9.6% of the tumor of men.
This diagram is showing the estimated cancer incidence by site and sex, and it is showing that about 0.9 million of the cases were reported for both in men and women in 2019. And the number one tumor for the male is prostate tumor, which accounts for about 20% of the total number of the cases, while the number two of the cancer was lung and bronchus, that accounted for about 13% of the cases, while number three is the tumor from the colon and rectum, that is about 9% of the total cases. So top three tumors in the male are from prostate, bronchus and lung, and colon and rectum, while for female the breast is number one site, and it accounts for about 1/3 of the all of the tumors for female, and number two is lung and bronchus, and number three site is the colon and rectum, which equates the tumor from the uterine corpus, that is also about 7%. This is the estimated cancer death by site and sex in 2019. In the United States, about 318,420 deaths were in men, while in female 282,500 deaths were reported. The major cause of the death in men was the tumor from the lung and bronchus, while the tumor from the prostate and colon and rectum were second and third in that category. The tumors in female, the leading cause of the death was also lung and bronchus, while the second one was breast and third one was the tumor from the pancreas, colon and rectum. All these four sites, they account for about more than 50% of the tumors in female. The leukemias and non-Hodgkin lymphomas, for both of these categories, the death rate is almost equal.
The lung cancers are a tumor of old age, and the age group affected is 55 to 84 years of age, while the peak incidence for this disease is 65 to 70 years of age. However, about 2% of the cases occur in less than 40 years of age. There is a strong association of this tumor with cigarette smoking, and drastic changes are seen with changing in smoking habit.
The cancer account for about 1/5 of the mortality in USA. This graph is from the Center for Disease Control and Prevention, CDC USA, and it is showing trends in age-adjusted cancer death rates by site between 1930 to 2017. You can see that the cancer was on higher side during early 20th century, while these mortalities are decreased during early part of 21st century. After the introduction of screening programs for various cancers, there is a noticeable decrease in lung cancer mortality. Prostate and other cancer mortality is also decreased due to screening program and introduction of new treatment modalities. The mortality from liver and pancreatic tumor is increased, and the pancreatic tumors have got distinctively bad prognosis, and patient dies usually within 6 months of the diagnosis. This graph is also from the Center for Disease Control and Prevention. It is showing trends in age-adjusted cancer death rates for females during same period, and that rate due to uterine tumors are increased recently, and the lung, bronchus and breast tumors are decreased, due to early screening and removal of the tumor at an earlier stage.
There are many ways to classify lung tumors. One is the primary and secondary tumor. The most common, the carcinomas are about 95% of the tumor of the lung, while this site is also a common area for the secondary tumors, all the carcinomas and sarcomas from the body. So the epithelial tumors are benign, dysplasia and malignant, three major groups. The benign are papilloma and adenoma, while dysplasias and carcinoma in situ, and the malignant tumors are bronchogenic carcinoma, collectively termed as bronchogenic carcinoma. These are of various histologic types. One is the squamous cell or epidermoid carcinoma, then a small cell carcinoma, that is pure or combined type. Adenocarcinoma has got five variants: SNR predominant, papillary predominant, lipidic predominant, and it was formerly known as bronchoalveolar carcinoma, solid predominant with mucin formation, and micropapillary predominant. Then there is large cell carcinoma and adenosquamous carcinoma. Other carcinomas are pulmonary neuroendocrine tumors, that are carcinoid tumor, and bronchial gland carcinomas, and these are adenoid cystic carcinoma and mucoepidermoid carcinoma. The soft tissue tumor of this area include fibromas, fibrosarcoma, leiomyoma, leiomyosarcoma, lipoma, chondroma, hemangioma, lymphangioma, granular cell myoblastoma, while the pleural tumors are mesotheliomas, both the benign and malignant types of the mesothelioma. Then the miscellaneous tumors of this area are carcinosarcomas, pulmonary blastoma, malignant melanoma, and malignant lymphoma. For simplicity, the lung cancers can be divided into small cell carcinoma and non-small cell carcinoma. The non-small cell carcinomas are adenocarcinomas and squamous cell carcinomas. The etiology of the lung cancer is linked to a well-known carcinogen, the cigarette smoke, and there is also association with the genetic factors and environmental factors. As far as the etiopathogenesis of the lung cancer is concerned, it has been linked with the tobacco smoking since long, and 80% of the cases of the lung cancer are smokers or recent quitters. There is linear correlation between the lung cancer and pack years of cigarette smoking, and smokers have got about 60 to 70 times more chances of occurrence of this lung cancer. However, 10 to 15% of the cases occur in non-smokers, and these are linked with other factors. For unknown reasons, women are more susceptible to the lung cancers, and an average active smoker has 13 times higher risk, while a passive smoker has 1.5 time risk of lung cancer than a non-smoker. The cessation of smoking decreases the risk of lung cancer over time gradually, but it never touches the baseline level. Pipe and cigarette smoking is has also got modestly elevated chances of occurrence of lung cancer. Chewing tobacco is an alternative by some smokers, but it has been linked with the increased occurrence of oral cavity cancers and nicotine addiction. Vaping, that is a new phenomenon, but some people say that it is not linked with the say lung cancer, but the e-cigarette smoke contain about 15 times more amount of formaldehyde, and this chemical is associated with increased risk of lung, oral cavity, and bladder cancer. Secondhand smoke is also linked with the occurrence of cancer, and it is responsible for about 3,000 non-smoker deaths. Then there is a group of people who always challenge the medical science, and they used to say in general public that the cigarette smoke is not related with the lung cancer because they are a very heavy smoker since their childhood and they have not developed cancer, and they know many other people also, and they are not having cancer after decades of cigarette smoking. So another explanation to these people is that the cigarette smoking cigarette smoke has got many pro-carcinogens that are converted into carcinogen by the action of P40 P450 monooxygenase enzyme system that is polymorphic in nature, and there are some specific variants of these P450 monooxygenase enzyme system that that is related with more conversion of these procarcinogen into carcinogen, and it is therefore related with increased carcinogenesis or increased occurrence of the uh, lung cancer. Then there is another group, that is mutagen sensitivity genotype. When lymphocytes of some individual exposed to increased level of tobacco related carcinogen, they show more numerous chromosomal breakage, and these are termed as mutagen sensitivity genotype, and they have more than tenfold higher risk of developing lung cancer as compared to the control, and this is because of genetic variation in gene involved in DNA repair. The development of especially the squamous cell carcinoma is sequential. First, due to chronic irritation and stimulus to the carcinogenesis, there is metaplasia and hyperplasia, dysplasia, hyperkeratosis, parakeratosis, and dyskeratosis. Then there is carcinoma in situ development, and then it leads to invasive carcinoma. So it is sequential, and it is due to acquisition of stepwise acquisition of genetic changes that occur during the course, and it is more related to squamous cell carcinoma. There is a linear correlation between the amount of the exposure of cigarette smoke and the appearance of the epithelial changes. The industrial hazards are also linked with the etiopathogenesis of the lung cancer, and exposure to asbestos, arsenic, chromium, uranium, nickel, vinyl chloride, and mustard gas has also been linked with this. Among these industrial hazards, asbestos is well studied, and this asbestos exposure for 10 to 30 years latent period develops lung cancer. The lung cancers are 5 times more common in non-smokers, while the cigarette smoking plays a synergistic role, and it is 55 times more common in smokers. Then ionizing radiation has got the role in etiopathogenesis of lung cancer, and the lung cancers are more commonly seen in Hiroshima and Nagasaki atomic bomb survivors, and also the cleaning workers of Chernobyl disasters. Then uranium that is weakly ionizing is also associated with this lung cancer, and it has got about 4 times more chances in non-smoker and 10 times more occurrence of the lung cancer in smokers. So the factors such as air pollution is also associated with etiopathogenesis of the lung cancer. Irritant particulates are linked with the cancer, as chronic exposure to the particulate creates irritation of the lung, and there is chronic inflammation development, and this development of chronic inflammation, it provides a fertile soil for the development of cancer. Then radon was linked with the workers of the uranium miners, but it is this radon is a ubiquitous radioactive gas that is present not only in the uranium miners, but it is present also in underground miner and worker in the below that work below the ground, such as subways, tunnels, and basement, and they are at increased risk of radon exposure. So, due to this, there were increased concern that the low-level exposures of the radon are associated with development of lung cancer. Then vitamin A deficiency is also linked with the etiopathogenesis of the cancer, especially the smokers with low level of vitamin A intake have a greater risk of lung cancer than those with vitamin A rich diet. Chronic scarring, it has seen that the peripheral adenocarcinomas are more common in the scars that are developed in the old tuberculosis, asbestosis, chronic interstitial fibrosis, and infarct and scleroderma. The etiopathogenesis of the lung cancer is also linked with acquired mutation. There are two types of mutation. One is the passenger mutation, and another is the driver mutation. The passenger mutation or hitchhiker mutations are there, but they do not induce any uh, cellular neoplastic changes. But these are the driver mutation that are responsible for the proliferation of the cell and development of the cancer in the pulmonary epithelial cells. There is another concept of the field effect, as we know that the carcinogen do not go specifically to a cell. It usually affects a large field or large area of the tissue or cell. So there may be presence of single or other mutations that are there, but they do not exhibit the morphological alteration or the development of the cancer, but the specific morphologic alteration is due to specific set of mutation, acquisition of this specific set of mutation, and every type every set of mutation is associated with a specific morphology of the tumor, a specific morphology or a specific molecular subtype of the tumor. The adenocarcinoma are the tumors that are more common in the people who never smoked, but it is also seen in smokers. Though the number of the tumor in non-smokers is more. It is associated with gain of function mutation in involving the components of growth factor receptor signaling pathway in about 1/3 of the cases, and commonly associated are epidermal growth factor receptors that is present positive in 10 to 15% of the cases, more common in Caucasian and more common in non-smoking Asian women, and anaplastic lymphoma kinase is present in 3 to 5% of the cases. ROS proton cogen 1 receptor tyrosine kinase 1%, and mesenchymal epithelial transition factor receptor MET gene is present in 2 to 5%, and read gene, that is rearranged during transfection gene, is present in 1 to 2% of the cases. Gain of function mutation in serine threonine kinase is also associated with this adenocarcinoma, and BRAF and phosphoinositol kinase are present in 2% of the cases each. Gain of function mutation is in KRAS gene is seen in about 30% of the cases. Then there are some genetic mutations that are associated with the squamous cell carcinoma of the lung, and this squamous cell carcinoma is associated with exposure to tobacco smoke. During its early uh, initial phase, chromosomal deletion that involved tumor suppressor loci such as short arm of chromosome 3 and short arm of chromosome 9 that are the site for cyclin dependent kinase gene, and short arm of chromosome 17 that is the site for the TP53 gene are deleted, and this occurs early in the tumor development. Then mutation in TP53 and P53 protein overexpression is present in 10 to 50% of squamous cell dysplasia, and 60 to 90% of the squamous cell carcinoma in situ are associated with mutation in TP53 and P53 protein overexpression. Then cyclin dependent kinase 2A tumor suppressor gene that encode P16 is present in 65% of the cases of squamous cell carcinoma. Then amplification of fibroblast growth factor receptor 1 tyrosine kinase is also seen. The small cell carcinoma are always smoking associated, and they have got highest mutational burdens. They have got universal inactivation of both TP53 and RB. Transformation of non-small cell carcinoma type to the small cell carcinoma is due to acquisition of RB loss of function mutation. Then there is loss of chromosome short arm of chromosome 3, and this is present in all of the small cell carcinomas. MYC gene amplification is also present. This molecular information proved very helpful in the treatment of lung cancer, as numerous molecules have been identified that work on specific targets, and these are the uh, uh, chemotherapeutic agents. One is the uh, one acts on epidermal growth factor receptor that is common in adenocarcinoma, and these adenocarcinoma are more common in non-smokers and Asian women, and the molecular target for this mutation is identified is erlotinib and gefitinib. Then there is no drug that has been identified for KRAS. There is mutation in codon 12 and 13, and these KRAS mutations are present in adenocarcinomas, large cell carcinoma, squamous carcinomas, and rarely present in small cell lung carcinomas. They are correlated with cigarette smoking, and they have got a poor prognosis. And as I told you earlier, there is no specific molecular therapy that is available for this. Then EML4 ELK translocation or echinoderm microtubule associated protein like 4 EML1 anaplastic lymphoma kinase mutation is present in pulmonary adenocarcinoma. It is also associated with cigarette smoking and has got a poor prognosis, but a molecular target for this is crizotinib. If we look at other mutations, the MYC amplification is present in 10 to 40% of small cell carcinoma, while P53 mutation is present in more than 80% of small cell carcinoma, and about half of non-small cell tumors or carcinomas. The RB is mutated in more than 80% of small cell carcinoma and about quarter of non-small cell carcinomas, and chromosome 3 deletion is present in almost all types, while BCL2 mutation is present quarter of squamous cell carcinoma and 10% of adenocarcinoma. P10 mutation is associated with poor prognosis and drug resistant. FGFR1 is present in about 20% of squamous cell carcinoma, and the inhibitors for this gene mutation are under trial right now. Other mutations that are present in minor percentage are BRAF, phosphoinositol 3, ERBB2, ROS, REAT, and many others. About a quarter of cases of lung cancer occur in the people who never smoked, and this percentage is about 10 to 15% in Western countries. The females are more commonly affected, and the histological variety in the non-smokers is adenocarcinoma, and often it is targetable. The mutations that are commonly present are epidermal growth factor receptor commonly, but rarely TP53 mutation are also seen. They never have KRAS mutation. Four precursor or pre-invasive lesions of these lung cancer have been identified. These are atypical adenomatous hyperplasia, adenocarcinoma in situ, squamous dysplasia and carcinoma in situ, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. And obviously, it is not necessary that this precursor lesion will definitely form a malignant lesion. It is not possible to distinguish between the precursor lesion that become a malignant one and the precursor lesion that remain localized or the precursor lesion that regress. The histologic classification of malignant epithelial lung tumor is important for treatment purpose as well as epidemiological and biological studies. There are many types, histological types of these lung tumors. One is adenocarcinoma, and the subcategories in adenocarcinoma are lepitic, acinar, micropapillary, papillary, and solid, according to predominant pattern that is present. And then there is invasive mucinous adenocarcinoma and minimally invasive adenocarcinoma, non-mucinous or mucinous variety. Squamous cell carcinoma, keratinizing, non-keratinizing or basaloid type. Then there are neuroendocrine tumors such as small cell carcinoma, combined small cell carcinoma, large cell neuroendocrine carcinoma, combined large cell neuroendocrine carcinoma, carcinoid tumors, typical and atypical both. Then there are other uncommon types of the tumor such as large cell carcinoma, adenosquamous carcinoma, sarcomatoid carcinoma, pleomorphic spindle cell giant cell carcinoma, and carcinosarcoma, pulmonary blastoma, other tumors such as lymphoepithelioma like carcinoma and nut carcinoma, salivary gland type tumor. Then the adenocarcinoma comprised about half of all the lung tumor. It comprised about 50% of the cases. The squamous cell carcinoma is 20% of all the lung tumors, while the small cell carcinoma of that comes in the under the head of neuroendocrine tumor, the small cell carcinoma are 15%, while the large cell carcinoma comprise about 2% of the cases, while these other uncommon varieties or totally they comprise about 13% of the cases. The combination of the malignant epithelial lung tumor also exists, such as squamous cell carcinoma plus adenocarcinoma that is present in 14% of the cases, and squamous cell carcinoma plus squamous cell carcinoma in combination occurs in 5% of the cases. This table is showing the frequency of lung carcinoma histologic types by gender. This data is from surveillance epidemiology and end result for the 2006 to 2010, and here it is showing that the adenocarcinoma in female are more common, while in men the squamous cell carcinoma are common. The carcinoid are twice as common in female than in men. However, adenocarcinoma has become a common histologic variant in both gender during last 2 decades. It has now replaced squamous cell carcinoma for male, and in both the men and women in both genders, the common type of lung cancer is adenocarcinoma. The reason for this change is unknown, but two possible etiologies are there. One is the increased trend of cigarette smoking in female, and second is the changes in cigarette type that lead to deep inhalation, such as use of filter with the cigarette or shisha inhalation or other type of cigarettes that lead to deep inhalation of the smoke. Now turning to morphology of the lung cancer, the tumors that are present in the hilar area tend to be squamous cell carcinoma, and these may be precursor lesions also. Then the tumors that are located more peripherally are usually of these are adenocarcinoma variety. Now precursor or pre-invasive lesions. Morphologically, the atypical adenomatous hyperplasia is a small lesion. It is a putative precursor lesion for adenocarcinoma and less than 5 millimeter in size. It is composed of, as it is evident from this photomicrograph, it is composed of dysplastic pneumocyte and dysplastic epithelial cells that are lining the alveolar wall, and these are cuboidal cells, and the alveolar wall also shows some fibrosis. These lesions may be single or multiple, and they may be present in the lung adjacent to the tumor, or they may be present away from the tumor. It is, however, unclear that whether all the foci of atypical adenomatous hyperplasia will progress to the development of adenocarcinoma, or if all the adenocarcinoma that arise, they are via this sequence of event, the classical adenoma adenocarcinoma sequence. This photomicrograph is showing atypical adenomatous hyperplasia. This is a very small millimeter sized bronchoalveolar proliferation which have got ill-defined margins, and there is mild thickening of the walls of the alveoli, and there is these thickened alveolar walls are lined by hyperplastic pneumocytes, and there is minimal atypia. The adenocarcinoma in situ was previously known as bronchoalveolar carcinoma. It is about 1 to 5% of the lung adenocarcinoma, and the size of this tumor is less than 3 centimeter. It is composed of entirely dysplastic cells that grow along the pre-existing alveolar septa. This pattern is termed as lapidic pattern of growth. It is a pattern of cell proliferation along the lining of the alveolar structure of the lung. Then these cells are more dysplastic than the atypical adenomatous hyperplasia, and they may not have intercellular mucin. Here in this picture, this is showing a focus of this adenocarcinoma in situ, and this adenocarcinoma in situ is showing that this lapidic growth pattern, and the cells are a bit, all cells are dysplastic, but there is no invasion. This is a mucinous type. As you can see, there is a lot of mucin that is lying over there. This photomicrograph is showing adenocarcinoma in situ, and there is circumscribed non-mucinous tumor that is growing purely within the lapidic pattern, and there is no invasion or scarring seen. Compare this picture with the earlier adenomatous hyperplasia, and this adenomatous hyperplasia, these are less hyperplastic, and adenocarcinoma in situ has got more pleomorphism as well as the crowding of the cells. but there is still no invasion. This is the high power view of this adenocarcinoma in situ that is showing that these atypical pneumocytes are lining the alveolar wall, and they are progressing in lipidic pattern. This is another photomicrograph that is showing the adenocarcinoma in situ, and this was previously known as bronchoalveolar carcinoma. In the lower field, you can see that there is a so-called the lipidic growth pattern, and these are neoplastic cells. These neoplastic cells are well differentiated, and these are columnar in variety. There is no invasion, and they tend to proliferate along the framework of the alveolar septa. This variety of the tumor, the adenocarcinoma, that is in situ, has got 100% 5-year survival. So it has got excellent prognosis. While if there is a mucinous variety of this tumor, the mucinous variety presents as pneumonia-like consolidation on X-ray. On gross examination, adenocarcinoma in situ are poorly defined, involve lung lobe as a pale tan to gray appearance, and the borders are irregular as is shown in this picture and marked by this arrow. The adenocarcinoma in situ on radiological examination, as seen here in this chest X-ray, they show loculated pleural effusion, and they may mimic pneumonia as areas of consolidation similar to the pneumonia are seen in these. This CT image in adenocarcinoma in situ is showing the involvement of the right lung with areas of consolidation that are similar to the pneumonia. Adenocarcinoma are the invasive malignant epithelial tumors with glandular differentiation or mucin production by the tumor cell. There are many patterns of these adenocarcinoma. These can be acinar, forming many acini. The tumor cell may crawl along the fibrous septi, hence they form lapidic pattern. They may form numerous papillae, and hence termed as papillary tumors or micropapillary tumor, or they can present a solid nest of the tumor cells with a few acini forming the mucin. These tumors tend to be located more peripherally, and they are smaller in size. They are positive for thyroid transcription factor 1, that is termed as TTF1, and this TTF is a protein. TTF1 is a protein that is considered to be responsible for maturation of the lung during embryogenesis, and it was first isolated from the thyroid, hence it is termed as thyroid transcription factor. And at the periphery, the tumor cells, they show the lapidic pattern in which the cells crawl along the normally appearing the alveolar septi. There is a variety that is termed as microinvasive adenocarcinoma. It is a tumor of less than 3 centimeter with a small invasive component that is less than 5 mm in size, and it is associated with a scarring, and peripheral lapidic pattern is present. It is important to identify this lesion because it has got a good prognosis as compared to other tumors of this size. Then mucinous adenocarcinoma, they tend to spread erogenously, hence they form satellite nodules, and the presence of the satellite tumors or some satellite nodules render them uh, less likely to be cured by surgery. They may present as a single nodule, more than one nodule, or they may affect the entire lobe. Hence, they mimic lobar pneumonia. This is the gross picture of invasive adenocarcinoma of the lung uh, that is affecting right upper lobe. The tumor is peripherally located, that has got irregular border, and the cut surface is tanned to gray, and it is associated with puckering of the overlying pleura. This is another gross picture of the lung that is showing a peripheral lesion, a small peripheral lesion that is solitary in nature, and this is invasive adenocarcinoma of the lung. The solitary nature of this tumor differentiate it from the metastatic tumors that are usually multiple. The microinvasive or minimally invasive adenocarcinomas are the tumor that have got uh, uh, focus of invasion. This focus is very small, it is less than 0.5 centimeter in size, and it is a non-mucinous adenocarcinoma. In this minimally invasive adenocarcinoma or microinvasive adenocarcinoma, the alveolar walls are lined by these atypical pneumocytes as is seen in this photomicrograph. And on careful scanning of the slide, there are areas of invasion, and as it is evident by this photomicrograph that these acinar glands are invading within a fibrous stroma. So this is the minimally invasive adenocarcinoma or microinvasive adenocarcinoma that has got a better prognosis of same size of the tumors. This photomicrograph is showing the lipidic growth pattern in an acinar, invasive acinar adenocarcinoma. Here there is the crawling of the malignant cell along the normal fibrous septi, and micro and an invasive acinar adenocarcinoma is present. In this photomicrograph, there is proliferation of type 2 pneumocyte and Clara cell, and this is along the surface of the alveolar wall. The Clara cells are non-ciliated bronchular secretory cells, and these are progenitor for the bronchioles, while type 2 pneumocytes are progenitors for the alveoli. This is the histological appearance of acinar adenocarcinoma, and this type of invasive adenocarcinoma, there is presence of round to oval malignant glands formation that are lined by these atypical epithelial cells. And here, this is papillary adenocarcinoma, in which the tumor cells, they tend to grow around a fibrovascular core. This is the micropapillary type of adenocarcinoma, and in this variety, the tumor cells are present uh, like in the papillae, they are around a central core, but these are smaller in size, and the fibrovascular core is not as prominent as seen in the papillary type. Here, this type of the tumor is solid adenocarcinoma, and this is associated with formation of the mucin, and there is formation of solid sheets of the tumor cells with several red intracytoplasmic mucin droplet that is stained red due to mucicarmine stain. Cut surface of a normal lung is spongy and grayish in appearance, but here you can see that the cut surface is solid, and it is glistening and mucoid in nature, a characteristic of invasive mucinous adenocarcinoma. On histology, here the tall columnar cells are filled with apical cytoplasmic mucin, and these neoplastic cells they are growing or crawling along the existing alveolar wall. This photomicrograph is showing that there are numerous glandular structures of variable size and shape are present, and these glandular structures are lined by atypical epithelial cells, and some of the epithelial cells are showing the mucin formation, and even the mucin droplets are also seen within the apical cytoplasm of some of the cells. The nucleoli of these neoplastic cells are also prominent. There are marked features of marked pleomorphism are also present. Both the cellular and nuclear pleomorphism are present. Now the squamous cell carcinoma of the lung. The squamous cell carcinoma are more common in men and they are affiliated with smoking. The precursor lesion for these squamous cell carcinoma are squamous metaplasia or dysplasia, and they take about years to develop into a carcinoma. So the development of squamous cell carcinoma follows the same series of events that occurs for epithelial malignancies, that is the metaplasia, and carcinoma sequence. And this carcinomatous change or these series of changes they occur due to acquisition of certain genetic changes or genetic mutation that are peculiar to that particular morphological lesion, as we have seen earlier. This is the respiratory epithelium, and it is showing that there is a goblet cell hyperplasia, and due to exposure to carcinogen or due to exposure to inciting stimulus or injurious stimulus, then this progresses to the basal cell hyperplasia. So morphological changes are occurring as a result of continuous exposure to the injurious agent. This further leads to the development of squamous metaplasia. Now the type of epithelium has changed into uh, squamous type from that of respiratory type of the epithelium. So uh, a more significant change now, it has increased in intensity. This change is now showing dysplastic changes. There are mutations. The cells are more crowded. They are showing more pleomorphism and hyperchromasia. And here in this picture, these cells are almost dysplastic, and they are now considered as carcinoma in situ. Still, they have not breached the basement membrane. Once they breach the basement membrane, it becomes carcinoma, squamous cell carcinoma. And here, this picture, the last picture, is showing the development of squamous cell carcinoma that is marked by these malignant atypical squamoid cells. Still, it is well differentiated. The malignant cells of the squamous cell carcinoma can be identified in cytologic smears of sputum or in bronchial lavage fluid or bronchial brushings. This picture is showing a large cell, and this is a keratinizing squamous cell. It is a large cell and has got a pleomorphic, deeply staining nucleus, and this is marked by this large arrow, while the small arrow is pointing toward the neutrophil that are present in this environment. Atypical cells may be seen in the cytologic preparation of the lung tissue, but still the tumor may not be detectable on imaging. However, it starts growing and may grow in many patterns. One of the growth pattern is exophytic. When the tumor grows exophytically into the bronchial lumen, it presents as an intraluminal mass. and when enlarged with progressive enlargement, it obstructs the bronchus, and obstruction of the bronchus will lead to distal atelectasis and development of infection. Then it may grow as a peribronchial growth, in which it penetrates the wall of the bronchus and then infiltrate along the peribronchial tissue and goes to the adjacent carina and mediastinum. It may grow as a intraparenchymal lesion. It grows along a broad front to produce a cauliflower-like intraparenchymal mass, as is evident in this gross photograph of the lung, in which the tumor is growing as an intraparenchymal mass, and it is compressing the surrounding tissue. Like all the tumors, this tumor grow as gray-white tissue, and this gray-white tissue is firm to hard in consistency, and when the tumors are bulky, they may present with the focal areas of hemorrhage and necrosis. These areas of hemorrhage and necrosis are marked by yellow or red mottling and softening of the tumor mass. When there is extensive necrosis, it may lead to cavitation of the necrotic foci. This gross appearance of the squamous cell carcinoma of the lung is showing that there is a tumor that is growing within the lumen of the bronchus. That is, this gray-white area is marked by the arrow that subsequently histologically proved to be a squamous cell carcinoma, and this squamous cell carcinoma is invading a local lymph node. These arrowheads are pointing toward the lumen of the bronchus. Histologically, the squamous cell carcinoma is characterized by presence of keratinization and or intracellular bridges. These arrows in this picture, this photomicrograph, the histological picture of the squamous cell carcinoma of the lung, these arrows are pointing toward these pearls, these squamous pearls that are the result of the keratinization, and the individual cells are deeply eosinophilic. The mitotic activity is high in poorly differentiated squamous cell carcinoma, while it is low in well-differentiated squamous cell carcinoma. Previously, more of these squamous cell carcinoma were in the central region, but now more peripherally located squamous cell carcinoma are being noticed. The area adjacent to the tumor may show squamous metaplasia, dysplasia, epithelial dysplasia, or foci of frank carcinoma in situ development, as these are the precursor lesion of the squamous cell carcinomas. Here in this photomicrograph of squamous cell carcinoma of the lung, the microscopic picture is showing the characteristic keratin pearls that are formed as a result of keratinization. The small cell carcinoma of the lung, it has been associated with strongly associated with cigarette smoking, and only 1% of the tumor, the small cell carcinomas, occur in non-smokers, and it is a highly malignant tumor that is present uh, in the major bronchi or in the peripheral regions. Unlike squamous cell carcinoma and the adenocarcinoma, there is no pre-malignant lesion identified for these small cell carcinomas, and as I told you earlier, it is the most aggressive tumor that metastasizes widely, and it proves always fatal. Histologically, it is composed of small cells. They have got scant cytoplasm and ill-defined cellular margins, and the nuclear chromatin is finely granular, that gives it appearance of salt and pepper. So it is also termed as salt and pepper appearance of the nuclei. The nucleoli are inconspicuous or absent. The cells are round to oval or sometimes maybe spindle shaped, and nuclear molding is prominent. Cell size is about 8 micron. It is small in size, and it is about 1/3 of a size of lymphocyte. The normal lymphocyte usually is about 25 micron in diameter. The mitotic count in these small cell carcinoma is high. This picture is showing that there is necrosis, and adjacent to the areas of necrosis, there is this aggregation of the tumor cells, neoplastic small cells. This necrosis is common and often extensively present in the tumor. There is another feature of these small cell carcinoma that is termed as Esoparty Effect. This Esoparty Effect is basically the basophilic staining of the vascular wall that is due to incrustation by the DNA that is derived from the necrotic tumor cells. Then there is presence of combined tumor that show that small cell carcinoma is mixed with non-small cell histologies such as large cell neuroendocrine carcinoma or spindle cell tumors. So this is the small cell carcinoma of the lung, the histopathological appearance, and here there is sheet of small oval to spindle shaped cells. The cytoplasm is scant in these cells, and the nuclear is finely granular. There is salt and pepper appearance of the nuclei, and the mitosis are marked by these arrows, and there is abundant mitosis seen in these tumors. On electron microscopy, these small cell carcinoma show characteristic dense core neurosecretory granules. They are about 100 nanometer in diameter, and they are present in 2/3 of the cases of a small cell carcinoma, and they are characterized by expression of neuroendocrine markers such as chromogranin, synaptophysin, and CD56. Uh, there is ability of some of these tumors to secrete hormones. One of these hormone is parathyroid hormone related peptide, and they are responsible for the paraneoplastic syndrome that is specifically attributed to these small cell carcinoma. So these characteristics give clue that the small cell carcinoma basically originate from the neuroendocrine progenitor cells that are present in the lining bronchial epithelium. However, presence of mixed tumor and transformation of the non-small cell carcinoma to the small cell carcinoma challenge this concept of the histogenesis of small cell carcinoma. Here in this picture, the tumor cells are composed of large cell, and they are poorly differentiated. So this is an undifferentiated malignant epithelial tumor that lacks the cytological feature of other forms of the carcinoma of the lung, and so it is a disease of or tumor of exclusion. As these tumors do not express marker for the either adenocarcinoma, squamous cell carcinoma, or the small cell carcinoma, the tumor marker for adenocarcinoma, as we have seen earlier, are TTF1 and nepsin A, or the tumor marker for squamous cell carcinoma are P40 and P63. So this is a diagnosis of exclusion. There is another variety, that is large cell neuroendocrine carcinoma. That is the in this variety, the cells are large, but the molecular characteristic of the tumor is similar to the small cell carcinoma. So the large cell with molecular characteristic of small cell carcinoma is large cell neuroendocrine carcinoma, While 4 to 5% of the tumor are combined in nature, they have got two or more of the type of squamous cell, basal cell, or the adenocarcinoma. So within a same tumor, there are areas of a different morphologic feature. This is the gross picture of the lung tissue that is showing peripherally there is a gray-white area, and this gray-white area later proved to be a large cell carcinoma of the lung histologically. There is presence of central SNR emphysema also in a smoker, and these large cell carcinoma of the lung are grouped as non-small cell carcinomas. This photomicrograph is showing sheets of large cells that are poorly differentiated, and they have got abundant cytoplasm, and the nucleoli of these cells are prominent. So these are the features of large cell carcinoma of the lung. Routinely, it is possible to diagnose the lung cancers by in a small lung biopsies and cytology specimen uh, by their characteristic morphology, but there is diagnostic dilemma in 20 to 40% of the cases of non-small cell lung cancer. In these type of the cases, they can be labeled as non-small cell carcinomas. Some of these are favor adenocarcinoma. Some of the non-small cell carcinoma favor squamous cell carcinoma, and another group is labeled as non-small cell carcinoma not otherwise specified. So uh, with the help of immunohistochemical stain, one for adenocarcinoma, that is TTF1, and one for squamous cell carcinoma, that is P40, are used in routine. And when the TTF is positive and P40 is negative, it is labeled as non-small cell carcinoma favor adenocarcinoma, but on light microscopy it is non-small cell carcinoma not otherwise specified. Similarly, when this immunohistochemical stain, the TTF, is negative on the same histology, but the P40 is positive, it is labeled as non-small cell carcinoma that favor squamous cell carcinoma. Then there is third diagnostic variety that is not otherwise specified, the non-small cell carcinoma not otherwise specified, and in this both of the immunohistochemical stains are negative. However, the histology is same. The characterization and the labeling of these diagnostic varieties is important to apply the targeted chemotherapy for the advanced lung cancer patients. So, ALK mutation, rearrangements, and epidermal growth factor receptor mutation should be carefully looked for in all of these tumors, because treatment is given accordingly. And if the tumor is negative for both and the mutation status is unknown, then the patients are eligible for pre-matrix or bevacizumab based regimens. The targeted therapy for squamous cell carcinoma is not established as yet, so their biological or their molecular nature is not tested routinely. So now the non-small cell carcinoma that favor adenocarcinoma on light microscopy, the tumor shows features of non-small cell carcinoma. There, there is presence of sheet of large cell. There is abundant cytoplasm and nucleoli are prominent. And these cells show strong positivity for TTF1, while while P40 is negative in these cases. This one is the finite aspiration cytology of this lung tumor that is stained by papineculo stain. It is showing malignant cells that are present in cluster and forming glandular structure, and they have got large hyperchromatic nuclei with some of these showing nucleoli. Now the non-small cell carcinoma that favors squamous cell carcinoma. In this case, the light microscopy is almost same as we have seen earlier. The tumor cells are composed of sheets of large cells, and these large cells have got eosinophilic cytoplasm with prominent nuclei, and some of these prominent nuclei have got prominent nucleoli also. The immunohistochemical profile of these tumor is negativity for TTF1, and these are positive for P40 immunostain. On fine needle aspiration cytology, these when stained with papiniclo stain, these tumors show cluster of cells with dense eosinophilic cytoplasm. The nuclei are hyperchromatic, and they show angulation also. The cells are elongated with pointed end, and all these features they favor the squamous cell carcinoma. Here this photomicrograph is showing that it is not very much clear morphology, as the tumor cells are composed of large cells, and they definitely are not showing any glandular or squamous differentiation, but this PS stain is showing that there is some presence of mucin, and intracellular droplet of mucin are also there that suggest the adenocarcinoma. So the morphology on light microscopy is still the same. In these non-small cell carcinomas, there is presence of sheets of atypical cells that have got large size, pinkish cytoplasm, prominent vesicular nuclei, and prominent nucleoli, and they are negative for both TTF and the P40 immunostain, hence they are termed as not otherwise specified. So now the spread of the lung cancer. The lung cancer may spread locally by crawling over the pleural surfaces. They can invade pleural cavity and can then spread into the pericardium. The nodes are also involved, and the frequency of nodal involved on average is more than 50, and the preferentially involved nodes are bronchial, tracheal, and mediastinal lymph nodes. The lymphatic spread as well as hematogenous spread both occurs in these lung cancers, but for the squamous cell carcinoma, the spread occurs late in its course. No organ is spared by this lung cancer, but more than half of the cases have shown the involvement of adrenal gland. The reason of this is unknown, while the frequency of liver involvement is 30 to 50%. The brain and bone are involved in 20% of the cases. The growth of the lung cancer can result in presence of secondary pathology, and sometimes the secondary pathology may be presenting complaint of that patient. Due to partial obstruction, there can be development of focal emphysema, or if they totally obstructive area, that it lead to development of atelectasis. The impaired drainage of the airway can present with ulcerative bronchitis, suppurative bronchitis, or bronchiectasis, while pulmonary abscess can the presence of pulmonary abscess can give a clue to the development of lung cancer. The superior vena cava syndrome, that is compression or invasion of the superior vena cava, present with edema of the head and arm, and the progression or growth of the tumor can lead to pericarditis or development of pleuritis with effusion. The Pencos tumor is a term that is applied to apical lung cancers. They tend to invade the neural structures around the trachea in the superior pulmonary sulcus, and they have got characteristic clinical presentation. They present with severe pain in the distribution of the ulnar nerve and with Horner syndrome, that is enophthalmos, ptosis, meiosis, and anhidrosis ipsilaterally. So this is Pencos tumor. The pulmonary tumor can be termed as occult tumor if it is present in the bronchopulmonary secretion. The malignant cells are present in the bronchopulmonary secretions, but there is no uh, clinical evidence of the tumor, clinical or radiologic evidence of the tumor. There is a TNM staging system for this lung carcinoma exists, and it is helpful in categorization of various lesions on which the treatment of these cancer is planned. So T stand for tumor size, and TIS or TIS is labeled the carcinoma in situ or adenocarcinoma in situ with pure lipidic pattern that is less than 3 centimeter, or squamous cell carcinoma in situ. Then T1 is the tumors that is about 3 centimeter or less than 3 centimeter without pleural or mainstream bronchus involvement. T1MI is minimally invasive adenocarcinoma. T1A is less than 1 centimeter. T1B is 1 to 2 centimeter, and T1C is the tumor that is 2 to 3 centimeter. Then T2 is the uh, notion for tumor that is 3 to 5 centimeter or involvement of mainstream bronchus but not of the carina, visceral pleura or lobar atelectasis. Then T2 can be further divided into T2A and T2B depending on the size of the tumor. Then T3 is the tumor that is more than 5 to 7 centimeter in size, uh, or one with the involvement of parietal pleura, chest wall, including superior sulcus tumor, the Pencos tumor, diaphragm, phrenic nerve, mediastinal pleura, parietal pericardium, or separate tumor nodule in the same lobe. T3, the main tumor or a separate nodule, or the tumor size 5 to 7 centimeter. T4 tumor is the tumor more than 7 centimeter or any tumor that has got the invasion of mediastinum, heart, great vessel, trachea, recurrent laryngeal nerve, esophagus, vertebral body or carina, or a separate tumor nodule in the different ipsilateral lobe. Then nodal involvement, if there is no metastasis to the regional lymph node, it is termed as N0. N1 is the ipsilateral intraparenchymal or peribronchial or chiral nodal involvement. N2 is metastasis to ipsilateral mediastinal or subcarinal lymph nodes involvement. N3 is metastasis to contralateral mediastinal or chiral lymph node. Ipsilateral or contralateral scalene or supraclavicular lymph node. Then nodal metastasis, M0 stands for no distant metastasis. Then the metastasis, no distant metastasis, or the M1 is the distant metastasis. M1A is the presence of a separate nodule in the contralateral lobe or pleura nodule or malignant pleura or pericardial effusion. M1B is single extrathoracic metastasis in a single organ. M1C is multiple extrathoracic metastasis. Then on the basis of these T and M, the tumor is staged into various stages from stage 0 to stage 4B. Now turning to the clinical features of the lung cancer, the lung cancers are aggressive and progressive in nature, and the commonly affected age group is 50 to 80 years of age, and usually the men in their 50s are affected with this tumor, and these patients have got symptoms for several months. The symptoms are cough that is present in more than 75% of the cases, while frequency of weight loss and chest pain is 40%, while dyspnea is present in 20% of the cases. The patient may present early in the course of the disease or late. Usually, the patient present in the late stage of the disease, and this frequency is more 70% of the cases, and about a third of the cases present earlier. The symptom of metastasis are back pain due to bone metastasis, headache, hemiparesis, cranial nerve damage, and seizures due to metastasis to brain. The only treatment available for the lung cancer is prevention smoking, and there are many people who smoke but they subsequently quit. But as we have seen in the epidemiology section of this tumor, their chances of having the tumor do not touch to the baseline. So early detection of these lesions is very important for the early recognition and early treatment of the tumor. And low dose computed tomography is used for these screening programs. But the false positive cases must be isolated to avoid unnecessary treatment. The 5-year survival rate for all type of the lung cancer is 18.7%, but for the localized tumors it is 52%, while the tumors with regional metastasis have got 22% prognosis, and the patients with the distant metastasis have got very little prognosis. They are only 4% of the cases. The small cell carcinomas have got highly malignant behavior, and they are most aggressive of these lung cancers. This is a chest X-ray in bronchogenic carcinoma, lung cancer. In this, there is a cancer that is present at the left hilum in the upper lobe, and there is mediastinal shift to the left due to post-obstructive atelectasis, and this haziness that is marked by this cross is due to infiltrate distal to the mass, and it is due to pneumonia. This is the computed tomography of the same case. In this, the carcinoma of the left hilum is present in the upper lobe on the left side, and there is atelectasis also with mediastinal shift, and infiltrates distal to the mass are also there. This chest X-ray is showing a peripheral location of the tumor, and this peripheral lesion that is present in this X-ray can easily be resected by wedge resection, and peripherally located tumor are usually adenocarcinoma, as we have seen earlier. The computed tomography image of the same case, here the peripherally located lesion is present in a non-smoker, and probably most of the peripherally located cancers in non-smokers are adenocarcinoma. This chest X-ray is showing a mass lesion in the left lower lobe, and later this lesion proved to be a large cell carcinoma on histology. These large cell carcinoma are seen in smokers with increased frequency. So we have seen and summarized all these effects earlier when we have studied the double pathology or presence of local effects of the lung tumor spread. So the symptoms are specific for specific pathology, like cough that is there in 50 to 75% of the cases. It is due to involvement of central airways. Hemoptysis that is present in 25 to 50% of the cases is due to hemorrhage from the tumor in the airway. The chest pain that is present about one-fifth of the cases is due to extension of the tumor into mediastinum pleura or chest wall. Pneumonia, abscess, lobar collapse are due to airway obstruction by the tumor. Lipoid pneumonia is due to tumor obstruction, accumulation of cellular lipids in foamy macrophages, and pleural effusion is due to tumor spread into the pleura. Hoarseness of voice is due to involvement of the recurrent laryngeal nerve, and dysphagia is manifestation of invasion of the esophagus. Paralysis of diaphragm uh, lead to clue to the phrenic nerve involvement. Rib destruction gives clue to the chest wall invasion, while superior vena cava syndrome is due to superior vena cava compression by the tumor. Horner syndrome is due to involvement of sympathetic ganglia, and pericarditis and cardiac tamponade are due to involvement of the pericardium. As we have seen earlier, the hemoptysis is one of the manifestations that affects about half of the cases of the lung cancer, but there are many other causes of the hemoptysis that are inflammatory, neoplastic, and various other causes of the hemoptysis. The inflammatory causes are bronchitis, bronchiectasis, tuberculosis, lung abscess, and pneumonia, while neoplastic are primary or metastatic lung cancer and bronchial adenoma. The other causes are pulmonary thromboembolism, left ventricular failure, mitral stenosis, trauma, foreign bodies, primary pulmonary hypertension, and hemorrhagic diathesis. Now turning to the treatment of lung cancer, the activating mutation in epidermal growth factor receptor or activating mutation in tyrosine kinase that are present in 15% of the cases of lung cancer can be treated by specific kinase inhibitors. One of these agent is crizotinib. Then the activating KRAS mutations that are present in about 30% of the cases, they have got worse prognosis regardless of the treatment applied. The squamous cell carcinoma and the adenocarcinoma subsets have been treated successfully by checkpoint inhibitor therapy. The small cell carcinomas are the most problematic and malignant tumors. They are sensitive to radiation therapy and chemotherapy, and after radiation and chemotherapy, the median survival is about only 10 months. New treatment for these tumors, these small cell carcinomas, are antibody drug conjugates that deliver chemotherapy selectively to the tumor cells, and immune checkpoint inhibitors. They are also under trial for the small cell carcinomas. Before closing this section on the lung cancers, I would like you to know some differences between the small cell carcinoma and non-small cell carcinoma. So one of the difference is the etiologic relationship. The small cell are strongly related to the tobacco smoking, while the non-small cell are smoking implicated with the other factors such as pollution, chronic scar, asbestos exposure, etc. Then morphology of both of these lesions is different. The pattern of a small cell is diffuse and in sheet-like, while the non-small cells are glandular pattern or squamous pattern. The nuclei are hyperchromatic and fine chromatin in small cell carcinoma, while the nuclei are pleomorphic with coarse chromatin in non-small cell carcinoma. The nucleoli are indistinct in small cell carcinoma, while nucleoli are prominent and abundant in non-small cell carcinoma. The cytoplasm is scanty in small cells, while cytoplasm is abundant and eosinophilic in non-small cell type of carcinomas. Dense core granules on electron microscopy are present in small cell carcinomas, while non-small cell carcinomas do not show any of these dense core granules. Neuroendocrine markers such as chromogranin, synaptophysin, neuron-specific enolase CD56 and CD57 are present in small cell carcinomas, while these are absent in non-small cell carcinomas. The epithelial markers such as EMA, epithelial membrane antigen, carcinoembryonic antigen, and cytokeratin are present in small cell carcinoma, while they are absent in non-small cell carcinoma. The mucin is absent in small cell, while the mucin is present in non-small cell, especially the adenocarcinoma. Beta 2 microglobulin is small or absent in small cell carcinoma, while in non-small cell carcinoma, beta 2 microglobulin is present. Peptide hormone production is more associated with a small cell carcinoma. There are variety of hormones secreted such as gastrin, adenocorticotropic hormone, ADH and calcitonin, while parathormone is secreted from the non-small cell carcinoma cell. Genetic abnormalities are distinct for both the varieties. In small cell carcinoma, 3p allele loss, RB and P53 mutations are seen, while in non-small cell carcinoma, 3p allele loss along with EGFR and KRAS mutation are seen. Treatment type: the small cell are sensitive to radiotherapy and chemotherapy, while non-small cell are uh, treated by surgical excision, and they have got also limited response to radiotherapy, and they can be treated by chemotherapy or targeted immunotherapy. Pause the video over here and recall this clinical scenario we discussed in the start of the lecture. Just recall in your mind what test you're going to perform for to this patient and what can be the expected results of the biopsy of this lesion. And in text, where do you fit these symptoms you have, these signs and symptoms you have seen in the physical examination and clinical history. So possibly it is a bronchogenic carcinoma. This concludes section 1 of the lung tumors. The section 2 of this lung tumor, we will have some overview of the neuroendocrine tumors of the lung along with metastatic tumor and other rare types of the tumors.